chronic coronary artery disease to acute coronary artery disease. We've got a number of overview talks on that. But before we start, we're going to go over a number of cases in which patients will come in to determine optimal reperfusion and what you do there. So let's go with the question number one. You work in a community hospital 90 minutes away from the nearest referral center with subspecialists. A 48-year-old man awakes at 11 p.m. with typical angina. 30 minutes, he presents to you 45 minutes after the onset of symptoms. He just flew to Hawaii for 2 days of business meetings, returned 3 days ago on no medications, has no medical or food allergies. His exam in the ED is normal. He started on 2 liters of oxygen, given an aspirin, morphine, pain-free. He's got a hemoglobin of 13.8, mild elevation of white count. D-dimer is a little bit up. Glucose is 155. Chest x-ray is normal. Troponin is pending. You're called to the ED to see the patient. Not only do you see the patient, but you see this ECG. Abnormal. Now, the question is you arrive with that ECG, and the best recommendation is to transfer to a referral facility, thrombolysis, and then transfer to a referral facility, thrombolysis and admit to your intensive care unit, heparinize and get a CT of the chest and serial labs, take a look at that ECG, and we'll go back and show that you're 90 minutes away from a referral center, and he had the pain 45 minutes ago. Okay, so let us know what you are going to do with this gentleman. Go ahead. Okay, Greg, take a look at what they got here. Okay. All right, question number 2. 56-year-old woman presents severe chest pain progressing to 10/10. Shortness of breath. Impending doom, presented 30 minutes to a rural community hospital. No medications, there's examination, she's anxious, lungs are normal. Cardiac exam, pretty normal, except for a 4th heart sound. Stat labs are pending, 2 liters of oxygen, aspirin, morphine, nitroglycerin, unfractionated heparin, bolus, and drip. This is her ECG. Looks abnormal. Okay, when arranging a 2-hour transfer to the regional referral center, so this means it takes 2 hours to get there, right, Greg? Okay, so it's going to take you 2 hours to get there. What are you going to do? You're going to give IV bolus of TNK plus eptifibatide, TNK plus heparin, TNK plus clopidogrel, TNK plus metoprolol, TNK plus furosemide, TNK plus enalapril. Let's see what you would do. All right. Okay, question number 3. 71-year-old mechanic presents with intermittent chest pain, takes aspirin for arthritis and pills for diabetes and hypertension. He presents, his ECG is unremarkable, his heart rate is 90, blood pressure is 120. He has 1 to 2 millimeter ST segment depression in V2 and V3. Troponin's elevated, creatinine's 1.8. He tells you his father died undergoing coronary angiography and he doesn't want a risky procedure. What do you tell him in regard to his clinical management? He can be safely dismissed on medical therapy alone. Coronary angiography with consideration of revascularization is the next step. Complications from PCI occur 1 in 1,000. And you're lucky it's daytime because otherwise you'd have to call the cath lab in from home and they need rest after your board review course. All right, so which one are you going to tell him in regard to his clinical management? Okay. So, what we're going to do now is have an overview on assessment and reperfusion strategies for patients with acute coronary syndrome. I've asked Dr. Greg Barsness, who's one of our superb catheterization guys, as well as now the director of our coronary intensive care unit, to come up and talk about both all types of patients coming in with acute coronary syndromes and what we're going to do in terms of intervention. Now, what we've done is we've kind of categorized things differently here, because Greg's only going to talk about the interventions, and then what we're going to do is we're going to have a double set talking to us about adjunctive therapies for the interventions or the non-interventions, depending on whether it's going to be a STEMI or a non-STEMI. So, Greg, come on up and give us your stuff.
All right. Well, thank you very much, and welcome everyone on this beautiful Rochester day. I appreciate your attendance. I will be, in fact, talking about the strategies of treatment, of assessment and treatment of patients with acute coronary syndromes. This is a spectrum of disease, and we'll talk about both unstable angina, non-ST elevation infarction, as well as ST elevation infarction, the two sides of this talk. I won't go into specifics of the medical therapy, but instead really focus on the strategies that have been highlighted in the clinical guideline statements and are utilized in practice and should be part of our routine care. So you all have our objectives, but basically we're going to talk about initial evaluation and triage of patients with acute coronary syndromes, ST elevation or non-ST elevation. We're going to identify early invasive versus ischemia-guided approaches to non-STEMI. That's the preferred term. We're going to select optimal reperfusion therapy for patients with ST elevation infarction and describe the optimal use of the pharmacoinvasive approach. These are all terms that we'll be well familiar with at the end of the talk. As I mentioned, acute coronary syndromes are a spectrum of disease, really from unstable angina to ST elevation infarction. The treatment of these problems is based on a similar understanding of pathophysiology and a similar approach to early reperfusion and revascularization, really regardless of the label. But we will talk about how that impacts our care. We know that across the world, cardiovascular disease is the leading cause of death. Coronary heart disease is the leading cause of cardiovascular disease. And although there's been some stability in the United States as far as incidence of disease, there continues to be a high burden of disease, and in fact, there are about 5 million ED visits for chest pain each year, 1.5 million admissions for ACS, about 1 MI every 30 to 45 seconds in the US, and about 70%, and actually a growing proportion, of the infarctions are non-ST elevation infarctions in the United States. This is important because non-ST infarctions are generally associated with greater comorbidities, perhaps greater age, and the mortality associated with non-ST infarction is actually greater over the ensuing years than with ST elevation infarction. And in fact, we've had an impact, a beneficial impact on the mortality of patients regardless of their presentation of ACS, but the overall mortality is higher with non-ST infarction than with ST elevation infarction. So when we talk about strategies of care for acute coronary syndromes, we need some sort of framework, and that's the basis of this talk. We need a framework to discuss. We need common definitions. We need common terms. We need a common framework to go by when we treat. And the reason is because treatment can be very complex. You see, if we've got a variety of anticoagulants, antiplatelet agents, cath lab strategies, all of those things lead to at least 144 different combinations of strategies with different risk of bleeding, different potential benefits. And so we have guidelines to guide us, and I would suggest that you all be very familiar with the most recent guidelines, which just came out within the last 18 months. Very important that you have a sense for what these guidelines state. So let's get started. The learning objective number 1 is to describe the initial evaluation and triage of these patients, and in fact, this is critical. We know that when patients present with chest pain, they could have a variety of causes for their chest pain, and acute coronary syndromes is just one of those potential causes. And so the first step with a Class 1 indication in the guidelines is to assess the likelihood that the symptoms that the patient is presenting with actually are attributable to acute coronary syndrome. We give them a high, intermediate, or low likelihood of presenting with an ACS by using their history, exam, ECGs, and biomarkers. So we can tell that if they, based on those parameters, whether they are likely or not so likely to have acute coronary syndromes. Now, if we've determined that they have a high or intermediate likelihood of acute coronary syndrome as their presenting complaint, then we deal with prognosis. So that's the next thing. And so if ACS is likely, what is the prognosis of this patient? And that's important because that will guide the intensity of our medical treatment. It will help us decide on an early versus a delayed invasive, or now termed a ischemia-driven strategy. And our tools for this prognosis are an ECG, which is to be performed within 10 minutes and repeated frequently if there's a change in symptoms or increased suspicion for a change. Biomarkers, and in the most recent guidelines, troponins, high-sensitivity troponins, are recognized as the preferred biomarker, and most strategies involve now repeating every 3 to 6 hours these troponins in order to assess the likelihood, or the prognosis of ACS. Beyond that, we have risk scores that are available to us, the TIMI, GRACE, Pursuit, and a variety of other risk scores, and we'll talk about those briefly. And in fact, we know that troponins alone are very helpful in gauging prognosis. You see on this slide, troponin I levels are associated in really a curvilinear relationship with death at 42 days in the TIMI trials. This is a profound relationship and very helpful in assessing prognosis and risk over a relatively short term. However, we know that there are a variety of reasons that troponins can be elevated in the absence of acute coronary syndrome. And you don't have to memorize this list, but I do break these items down into myocardial injury or strain issues versus systemic toxic metabolic issue. Just looking over this slide before boards can be helpful just to kind of get some familiarity with some things that might impact troponin levels that are outside of the realm of ACS. But the inability or the confusing issues with troponin interpretation can be overcome to some extent by risk scores, so a more robust score. And of course, TIMI score has been around for quite a while. We know it's a 7-item score that can predict death, MI, ischemia, requiring revascularization at 14 days, and is, again, in a fairly robust curvilinear relationship. So TIMI risk scores of 1 or 2 or 0 are felt to be low risk. 3 and above are much higher risk. And you can see that that's a fairly robust relationship. Another score that's utilized frequently but is less intuitive, less amenable to just bedside use is the GRACE score. It requires a computerized algorithm. You can get it on this website, but you put in a couple of presentation features and you get a score. And that score is robust. You see it's based on the Killip class, blood pressure, heart rate, age, creatinine level, other risk factors, and you get a score that's, again, very reliable and reproducible for prognosticating both in-hospital 6-month and even 1-year outcome in acute coronary syndromes. So once we've determined likelihood and prognosis, how do we use that information? What do we do with these patients? One of the issues is to distribute patients into an ischemia-guided versus an early invasive strategy. So that's delayed invasive or early invasive, but the preferred guideline recommended term is ischemia-guided. And you can see that, by and large, over the years, the vast weight of data has suggested that an early invasive approach is superior to a delayed invasive or ischemia-guided conservative approach. And in fact, there's a 25% relative mortality risk reduction over a period of 2 years with an early invasive approach versus a delayed or conservative approach. Looking at one of those trials, in particular, the Tactics TIMI-18 trial, and looking at 6-month MACE rates, you can see that the point estimate across the spectrum of demographic items is favorable for an early invasive strategy. If you look carefully, though, early invasive strategy is highly effective in those higher risk groups, including patients with diabetes, ST segment changes, and troponins that are elevated. And in fact, if you stratify by TIMI risk score, you can see that there's a linear relationship with a higher risk having a greater impact with an early invasive strategy. So early invasive strategy is very effective, profoundly effective in patients with high risk, with a less impressive benefit in those lower risk patients. And so an early invasive management strategy is an option for nearly all patients. And in meta-analysis, the number needed to save one life, the number needed to treat to save one life, is about 62 with an early invasive strategy. So it's a very effective, very impactful strategy in the vast majority of patients. Looking more carefully at the risk stratification degree and the impact of an early invasive strategy, you can see in the TIMAX trial, the TIME ACS trial, where patients who were all treated with an early invasive strategy. So everybody was meant to have early angiography within 48 hours, which we'll talk about in a bit. They were stratified to less than 24 hours versus a delayed early invasive approach of more than 36 hours. And so at an average time of 14 hours versus an average time of 50 hours, you can see that in low to intermediate risk patients, shown on this graph in white and yellow, there was really no impact with an early invasive strategy. So low risk didn't seem to benefit that much from an early strategy compared to a more delayed strategy of angiography and intervention. However, when patients had a high risk, and in this case a GRACE score of greater than 140, there was in fact a great separation of curves favoring an early invasive strategy, decreasing the cumulative hazard in this case. That has led to a Class 2A indication for early invasive strategy in this group. Looking further at a very high-risk group in the ABORD trial and very early intervention, you can see that there was not a great benefit in these secondary endpoints of peak troponin, major adverse cardiac event, and major bleeding. You can see that with an immediate, meaning 70 minutes, versus delayed, meaning 1 day, early invasive strategy, really no major impact. And so although it was shown to be safe to go very early, even in really high-risk patients, there wasn't a marked benefit that could be observed in this case. But this shows that it's safe to go very early and can be in the right setting. So how do we put all this together? What's the framework we use? Well, if somebody presents and when we think that the likelihood that they're presenting symptoms are intermediate or high likelihood for ACS, we initiate aspirin, beta blockers, nitrates, anticoagulants, telemetry, perhaps oxygen with oxygen saturations of less than 90%. You'll hear more about the medical therapy in the next talk. But after that, after we've given that baseline medical therapy, then we use our prognostication to decide how to best treat them. An early invasive strategy is appropriate for people with electrical or hemodynamic instability, refractory, resistant, or recurrent angina, and those patients are generally treated with angiography within 2 hours. So very early angiography for those patients who are unstable. Makes intuitive sense and is borne out by the data. Another group would be those with elevated risk scores, like we talked about in the TIME ACS trial, abnormal biomarkers or new ST segment depression changes. And generally, we would take them to the angiography suite within a day, because again, that's been shown to be beneficial in the TIME ACS and other trials. Finally, for an early invasive strategy as a preferred method, PCI in the past 6 months or prior CABG would be one group that could go on. Diabetes or stage 2 or 3 chronic kidney disease, that's important, stage 2 or 3. EF of less than 40%, or moderate risk score with a GRACE score of less than 140. And those patients would go within a day or two to early angiography as a preferred strategy. What about patients with a low risk? Well, in patients with a TIMI risk score of 2 or less, especially women have not been shown to have a beneficial outcome with early angiography and intervention in the setting of low risk. And in fact, in some studies, their outcome has been worse with an early invasive strategy. So yeah, an ischemia-guided strategy would be certainly a reasonable approach in women with a low risk. If women have a high risk or intermediate risk, early invasive strategy is fine. But in a low risk, especially with women, ischemia-guided strategy is preferred. If there's no ST segment deviation or negative biomarkers, then an ischemia-guided strategy is certainly possible. If there are recurrent symptoms or heart failure or serious dysrhythmia, worsening mitral regurgitation, or other structural or hemodynamic issues, transferring or crossing over to an early invasive strategy is fine. It's a great strategy, so that would be reasonable. However, if they remain stable, then going on to assessment of their EF or stress test. If their stress evaluation shows ischemia, or if the EF is depressed, then moving on to an angiographic approach is reasonable at that point. And so, in summary, for non-ST elevation infarction, an early risk stratification, verification, and prediction are essential in order to apply appropriate therapy. An early invasive strategy, meaning within 24 hours, is preferable in high-risk patients, including women. You should go within 2 hours if they're symptomatic or unstable, between 12 and 24 hours if they have a high-risk profile, within 72 hours if there are other risk features, including diabetes or coronary disease history, and a crossover from the ischemia-guided to an early invasive strategy is certainly reasonable. The optimal medical therapy and risk modification are essential, and you'll hear more about that in the ensuing talks. And that brings us to ST elevation infarction. Again, part of the spectrum of acute coronary syndromes that has a similar tone to the treatment. Again, we're going to want to identify patients. We're going to want to prognosticate for these patients. We're going to want to treat appropriately. And that's all within the guidelines, which again, I think you should be familiar with. There is a universal definition for ST elevation infarction. We are looking for a 1 millimeter or more of ST elevation in 2 or more contiguous leads. For men and women in leads V2 and V3, we have a slightly higher threshold for ST elevation to diagnose an ST elevation infarction, and that's important to know for boards and in practice. We also can look for a new left bundle branch block. Put that in quotations because identifying and ascertaining whether a left bundle branch is new or old is sometimes difficult. In the right setting, with the right patient, it's reasonable to treat a patient with left bundle branch block as an ST elevation infarction with certain caveats. And if the initial ECG is non-diagnostic, remember that you should repeat the ECG every 5 to 10 minutes, especially with changes in clinical syndrome, to catch ST elevation if it in fact occurs. Early management involves reperfusion and revascularization without any other options. All acute ST elevation patients warrant reperfusion unless the patient refuses. You can't coerce a patient into getting treatment they don't want, or if there's limited life expectancy from other reversible disease processes. And the resolution of symptoms, importantly, is not a reason to cancel or delay reperfusion. So once you diagnose an ST elevation infarction, you should proceed on with treatment as appropriate. You're all very familiar with this slide that shows the time intervals recommended for treatment of a patient presenting to an institution capable of treating ST elevation infarction. You see that our total ischemic time, the first medical contact to reperfusion time, is meant to be less than 120 minutes. That's our systems goal, that's our societal goal, that's what we want. We want everybody to have less than 2 hours of ischemia time. We can break that down by patient time. That's very hard to control, but we don't give patients much time at all to recognize that they're having an infarction. don't give the EMS much time at all to recognize that they should get to the patient and treat. But once the patient gets to the hospital, we're allowed 30 minutes for door to balloon, or excuse me, door to needle time for thrombolytics, or 90 minutes for door to balloon time for a primary PCI. So that's it for patients presenting to a hospital capable of treatment. Again, our goal societal time is 120 minutes of ischemia time. There's an associated time interval called the door in, door out time, or DIDO time, which is one of the performance measures. It is an accountability time for hospitals transferring for primary PCI. So in somebody presenting to a hospital where they don't do PCI, primary PCI, but the patient is to be transferred for primary PCI, DIDO time is very important because the amount of time it takes to get the patient to the next hospital to get their balloon inflation is a critical component. And in fact, we know that in a large registry, the ACTION registry, involving 14,000 patients, DIDO time had a really impressive impact on outcome, so that in-hospital mortality was 2.7% if the DIDO time was less than 30 minutes, which is our goal, but that mortality doubled if the DIDO time was increased. So we know that there is a marked impact of all of these time components on the outcome of the patient. So some definitions for ST elevation in infarction treatment and the importance of strategy. Fibrinolysis, of course, is thrombolytic therapy given as standalone reperfusion therapy. Primary PCI means that no lytics are given, so it's just the PCI and the associated adjunctive medical therapy that you'll hear about. Rescue PCI is PCI after failed thrombolytic therapy, so if there's evidence of non-reperfusion. And the pharmacoinvasive strategy, which is a preferred strategy in the guidelines and in practice, thrombolytic therapy is given, followed by elective routine angiography plus or minus PCI at a given time interval following transfer to a PCI center. So when we think about reperfusion, we think first about what we have had historically. Thrombolytics are still the most common form of reperfusion in the world, and that's okay because it works. Thrombolysis works. There's a marked 2% absolute mortality reduction with thrombolysis compared to non-therapy. And in fact, thrombolysis works across the spectrum of ST elevation presentations, whether it be bundle branch block, anterior MI, inferior, or other ST elevations. It doesn't work so well with non-ST infarction or ST depression, so we don't use it for ST depression. ECG at presentation is very important. But lytics work. So why consider primary PCI if lytics, in fact, are beneficial? And the reason is that there are shortcomings to fibrinolytics. There is thrombolytic sealing. There's a normal TIMI3 flow in only 50% of patients. There's hemorrhagic complications. 1% of patients will suffer an intracoronary or intracerebral bleed, which is frequently fatal. And there's a lot of bleeding in other sites as well. And the elderly, who have the most to gain from reperfusion, also have the highest risk of bleeding with thrombolytic therapy. So I've included in your slide deck the absolute contraindications to thrombolysis. The way to think about this is that anything that's going to affect your brain, any risk of bleeding in the brain is an absolute contraindication to thrombolytic therapy. And in those cases, you really should consider primary PCI. You don't want to avoid reperfusion therapy. You have to assess the risk and benefit, but in the absolute contraindication to thrombolytic therapy, consider primary PCI. That would be a good sort of question. So, time to reperfusion is an important element. We talked about our goal time is less than 2 hours of ischemia time. The modality that we use to achieve reperfusion depends a bit on time of presentation. So thrombolytic therapy we know is very effective, especially early in the course of thrombosis. So when a clot is fresh, patient's just presented with an ST elevation infarction, thrombolytic therapy is extremely worthwhile and effective. The risk of thrombolytic therapy is primarily of bleeding, and that risk increases gradually with time to the point where within a day, there is a crossover of this risk and benefit ratio so that we don't administer lytics very late. Primary PCI does have good benefit early on, that benefit does not wane as quickly because we're really able to do the same things in the coronary artery regardless of the time of since symptom onset. The risk, however, does gradually increase, but to a much lesser extent than with thrombolytic therapy, and it really is fairly flat throughout the course of early STEMI care. For these reasons, we think of thrombolysis as an excellent therapeutic regimen in patients who are presenting very early, less than 2 hours particularly. You can use lysis or primary PCI in those settings. If patients present later, the relative benefit of thrombolytic therapy is less. There's a little bit increased risk, and so we lean more towards primary PCI, especially in those patients presenting less than 2 hours or greater than 2 hours from symptom onset. And throughout all of this, we need to consider the possibility of a pharmacoinvasive approach, which we'll talk about in a moment. When we look at primary PCI versus fibrinolysis, there is a benefit to primary PCI when it's available, and in fact, the number needed to treat to prevent a death with primary PCI compared to fibrinolysis. In that other graph, it was fibrinolysis versus medical therapy without reperfusion. This is PCI versus fibrinolysis. The number needed to treat for a death to be prevented is 50. The number needed to treat to prevent death, MI, or stroke is only 17. So it's a highly effective therapy and should be employed whenever possible. Primary PCI is the best early reperfusion option if it's performed within 12 hours. These are class 1 indications according to guidelines. If the individual who's performing is performing more than 75 with a first medical contact to balloon of less than 90 minutes, centers need to be high volume centers, and surgical backup is preferred for a class 1 indication. If a patient has STEMI with shock or acute severe heart failure, irrespective of the time of MI onset, primary PCI is a reasonable approach. Class 2A recommendations would include primary PCI in 12 to 24 hour time frame after symptom onset, especially in patients who are unstable or who have recurrent ischemia. And class 3 recommendations are changing a little bit, and one class 3 recommendation would be to open an occluded vessel more than 24 hours after MI without symptoms. So in an asymptomatic patient who has an occluded infarct artery more than 24 hours after symptom onset, we tend to leave that alone. That's based on the OAT trial, the occluded artery trial, and that trial showed that there's no benefit and perhaps slightly increased adverse outcome if you don't adhere to that recommendation. We know that the guidelines related to non-infarct artery PCI are changing, and although it hasn't changed directly, I don't think that there will be a question based on non-infarct artery PCI at this point. There's a lot of controversy. We know from retrospective data that the best strategy is a staged PCI strategy, so a strategy in which you open the infarct artery, and sometime within 30 days you open all the other arteries that have stenosis. Recent trials have called some of that into question, but again, I don't think that there will be a question related to this issue, and you don't need to worry about it right now. More data is coming, and we look forward to that. So what about patients who have ST elevation infarction and you want to transfer to primary PCI? So you're not willing to give lytics, and you want to transfer. When do you do that? Well, STEMI patients presenting to a non-PCI hospital are best suited for transfer for primary PCI if they present with high-risk features, if they have a high bleeding risk from lytic therapy, or if they're real late presenters. In those patients, it's reasonable to consider transfer for primary PCI. That decision is a judgment decision made on considering the time required for transfer and the capabilities of the receiving hospital. And our goal, first medical contact to device time, is still less than 120 minutes. So you don't want to be sending people all across the country to get primary PCI if fibrinolytic therapy can be delivered promptly and effectively close to home. And importantly, if none of those things are present, if none of those high-risk features are present, lytics is reasonable, and then consider transfer to a primary PCI or to a PCI center for a pharmacoinvasive approach. And now we'll talk about what a pharmacoinvasive approach is. This involves the importance of medication timing and timing of angiography. So the pharmacoinvasive approach simply is giving full-dose lysis plus clopidogrel as a standard therapy, transferring to a PCI-capable hospital, not for PCI directly, but for stabilization. In case that the reperfusion doesn't work, then they can get rescue PCI, or if they do have ST resolution and their pain resolves, then they can be stabilized for a bit and go on to urgent or routine elective angiography with probable PCI within the day, between 3 and 24 hours after lytics. That's the pharmacoinvasive strategy. The non-PCI hospital triage and transfer algorithm looks like this. So if somebody presents to a non-PCI hospital and their symptoms are within 2 to 4 hours, if their bleeding risk is low, it's reasonable, again, because of the efficacy in this setting of fibrinolytic therapy, it's reasonable to give lytics plus clopidogrel and transfer for a pharmacoinvasive approach to a PCI center. If their bleeding risk is high, again, it would be reasonable to consider transfer for primary PCI. And if they present late, it's reasonable to consider transferring to a primary PCI center, possibly having given lytics even in that setting if the transfer time is going to be very long. When do we do delayed or elective PCI after lytics? Well, there's a class 2B indication in patients who are hemodynamically or who have a hemodynamically significant lesion in a patent infarct artery more than 24 hours after STEMI. So again, this is somebody who's had resolution of their symptoms or who had delayed presentation. They're perhaps still symptomatic, or even if they're not, but they have a patent vessel, it's just got a tight stenosis. It's reasonable to treat that, unlike the occluded artery, which I've already told you would not want to treat. And that's that late occluded artery, and that's got a class 3 indication. Stents can be used. They're appropriate in primary PCI as well as follow-up PCI. Bare metal stents can be used. Drug-eluting stents can be used, but it's important to assess the patient's compliance and ability to tolerate medications, including dual antiplatelet therapy, due to the risk of stent thrombosis following stent placement. Intra-aortic balloon pump counterpulsation can be used, but it's good for you to know that there's no survival benefit in association with primary PCI. So if somebody's got coming for primary PCI, we don't tend to waste a lot of time putting a balloon pump in. We open up the artery and treat because of a lack of survival benefit. LV assist devices can be considered, but they're difficult, they're cumbersome, and they have a 2B indication. Immediate angiography and PCI are indicated in out-of-hospital arrest, and therapeutic hypothermia, now called targeted temperature management, is also indicated. So for STEMI, early delivery of reperfusion therapy in all eligible patients reduces mortality and is indicated. The pharmacoinvasive strategy may be considered at non-PCI hospitals. Primary PCI within 12 hours is the preferred strategy, given local expertise and local logistics. A systems-based approach is essential, and the goal ischemic time is less than 120 minutes. And the optimal medical therapy and risk modification are essential components, just like they were with non-ST infarction. And with that, I think we'll move on to some questions.
Very nicely done. Let's go back to that question number 1. We'll go through that, and then we'll ask Greg a number of questions about it. So this is a community hospital 90 minutes away from the nearest referral center. So a 48-year-old man wakes up at 11 p.m., discomfort for 30 minutes, presented to the ED 45 minutes after the onset of symptoms. Denies other complaints, just flew in from Hawaii for 2 days of business meeting, returned 3 days ago. On no medications, no medical or food allergies. Examination in the ED is normal. Go to the next slide. So he was started on oxygen, given aspirin and 4 milligrams of morphine. By the way, how do you give the aspirin, Greg, in these guys?
Generally chewable. So usually 4 baby aspirin, chewable. It's preferred.
Patient now pain-free. Lab results show a little bit of elevation of white count, D-dimers a little bit up, sodium, potassium, creatinine's okay, glucose is 155, pulse ox is 97, chest x-ray is normal, troponin is pending. You're called to see the patient and show the ECG on the next slide. Okay, so you're no doubt about what's going on here. Okay, the question. You arrive at the ED. What do? Transfer to referral facility for angiography and coronary intervention, thrombolysis, then transfer to referral facility, thrombolysis, and admit to your ICU, heparinize, and get a CT of the chest and serial labs. So which one are you going to do? Okay, very good.
Very good. So that's even, so you learn something that's even better than before, and that's exactly right. So B, thrombolysis and refer to, then transfer for referral facility. That's the pharmacoinvasive approach. Again, this was an infralateral STEMI with early presentation, low risk for bleeding with lytics, and high likelihood of success. Unlikely to achieve that goal of first medical contact to balloon within 120 minutes, even if you immediately transferred for primary PCI. And this pharmacoinvasive approach is preferred because, as opposed to just giving the lytics and keeping him locally, if you transfer then after lysis to a primary PCI center or a PCI center, the patient can be observed. If they don't have relatively rapid reperfusion, they can go for rescue angioplasty. Or if they seem to have reperfused, they can go to angiography within 3 to 24 hours for elective PCI. It would be different, of course, if he'd presented later or had a higher bleeding risk, as we discussed.
So go back to those. How much later? So this guy presented within 45 minutes. What kind of are you using as your cutoff to determine whether or not you should transfer versus thrombolysis and transfer?
Sure. So certainly in the first 2 hours, lysis is reasonable. I think between less than 4 hours, especially with the prolonged transfer time, lysis would still be reasonable. When you get towards 6 hours and certainly beyond 6 hours, the likelihood that fibrinolysis will be effective is less, and there continues to be a high bleeding risk with a 1% stroke, hemorrhagic stroke risk, and so not giving lysis at that point would be reasonable and transferring directly for primary PCI, even if it's a somewhat prolonged transfer time.
Yeah. So Greg's little, I like your little thing where you had the kind of risk going up and the benefit going down. And about 6 hours after a STEMI, the thrombolysis benefit is going to be very small, and you would want to transfer those people, even if it's going to be 2 hours, right? 3 hours and stuff. Now, another question that came from the audience is, we're talking about thrombolysis now at a local ED, okay, because you don't want to transfer yet. What about if the patient came in on warfarin? Or even better, what if the patient came in on one of the NOACs? What would you do with thrombolysis at that time?
Yeah, those are hard. I think that generally it would depend. So the NOACs are a challenge sometimes, but we would still give lysis on top of the NOAC. If the patient has been sick for a while, is elderly, they're on warfarin and their INR is 5, then we might consider not giving lytics. So it depends a little bit on the patient demographics and the baseline characteristics, the type of agent they're taking. But lytics are safe-ish in that setting. They're just not, you have to take that into consideration when choosing your strategy.
Yeah, but unless they're at very high risk of bleeding with a super therapeutic INR, you would give lytics with warfarin, yeah, and you would give lytics with the NOACs.
That's right. Because remember, you're going to anticoagulate anyway, even with lysis. So you may be more judicious with your antithrombin medication in those settings of using NOACs or warfarin, but you'd still give thrombolytics.
Yeah. And then Wells, just to let you know, is that Wells and Nandon are going to go over the antithrombotic agents and the antiplatelet agents to use in these various situations. So we wanted to concentrate first on, the assessment that Greg talked about with the the risk of a therapy and what therapy to use, invasive, non-invasive, transfer, thrombolysis, and then the antithrombotics and antiplatelets are going to come a little bit later. Okay, so let's go to the next question. So here's a 56-year-old previously healthy woman, severe chest pain progressing to 10/10, sense of impending doom, presented within 30 minutes of the onset to the ED at a rural community hospital. Okay, so it's 30 minutes of pain on no medications, no allergies, blood pressure's 102, heart rate's, what's her heart rate here? Don't know her heart rate.
80.
80, okay. Venous pressure is normal, very anxious, lung sounds are normal, okay? Cardiac examination has a fourth heart sound, stat labs are pending, pulse ox is 96%, received 2 liters of O2, aspirin 325, 4 milligrams of morphine, IV nitroglycerin, 4,000 units unfractionated heparin bolus, drip at 1,000 units per hour. Here's her ECG here. Okay, so here's a woman who presents within 30 minutes. You know, huge ST segment elevation. Okay, now we're going to talk about concomitant therapy, but Greg, tell us before you get to the question about your decision on thrombolytic versus transfer in this woman versus the first one.
Yeah, so in this woman, she's a very early presenter. And I think that although if her heart rate was 120 and her blood pressure was 80, we might consider that shock, and then we might consider primary PCI as a preferred strategy, because that would be one of those items for transfer. But she's very early. She's hemodynamically stable at this point. Thrombolysis is likely to be beneficial, but probably lysis alone is not going to do it for her. So lysis and keeping her in the local hospital without access to PCI and aggressive hemodynamic support is probably not the preferred strategy. So lysis and something else would be preferred.
But in a non-PCI hospital this early, low risk for thrombolysis is definitely the thing to do.
Yeah, yeah.
Okay. Keep on. Even if you could get that to a hospital within an hour or 2 hours?
Even then, especially then, I think, because with 30 minutes of presentation, the chance that the lytics in a young woman are going to be beneficial is very, very high. And the risk is relatively low. And so there's very little to lose.
So that's incredibly important. Okay, very, very short time of presentation. Even if you can get to another hospital that does PCIs within an hour, 90 minutes or so, the chances of benefit from this thrombolysis are so great you're going to give it. Okay.
And the nice thing about the pharmacoinvasive approach is you get to do both. You get to give lytics, which are going to be beneficial, and you get to transfer, and you do them in concert. So that's the goal.
So let's go to the question then. Now you're going to transfer. You know you're going to transfer. What are you going to transfer with here? Okay, we'll let you read over, punch your answer in.
Ah, very good. That's a clapper, right?
It's a clapper.
All
You
right.
can clap.
Excellent. That's exactly right. So we showed multiple times that lysis given with clopidogrel is the strategy that is to be employed. As you'll hear about in the next talks, clopidogrel is one of the few things that have been shown to be advantageous and actually have a survival benefit in the setting of appropriate reperfusion therapy for ST elevation infarction. So very important to give clopidogrel. These other things are less beneficial. In fact, large ST elevation infarction with early presentation, as we talked about, pharmacoinvasive approach is preferred. More heparin, facilitated approach with glycoprotein 2B3A inhibitor. Neither of those things are indicated at this point. The risk of heart failure is high in this case. We just talked about that. So IV beta blockade or beta blockade at all, actually, would not be indicated in this particular patient. That's why that question was wrong. You wouldn't necessarily give Lasix or enalapril in this hypotensive or low normal tensive patient. So again, clopidogrel has a class 1 indication.
And you know, I think they're going to talk about it, but it never hurts to repeat. What about these other more expensive, fancy antiplatelet agents like prasugrel and ticagrelor? And things?
Right. So the data for ST elevation infarction in the setting of lytics is supportive of clopidogrel.
Only.
Only.
Yeah.
So with the non-ST infarction and in other settings, certainly the newer P2Y12 inhibitors are beneficial, and the other agents. So you will hear a lot more about that.
Okay, let's go to question 3.
Okay, I'm just going to.
71-year-old mechanic, intermittent chest pain, takes aspirin for arthritis, pills for diabetes and hypertension, comes into the ED. He's got a little expiratory wheeze. He has ST depression with an elevated troponin and a creatinine of 1.8. And he tells you his father died and really doesn't want this risky procedure. Okay, so what should we do? So let's go to the questions. And is he now pain-free? I think he's intermittent chest pain.
Stuttering.
Stuttering.
Okay.
Okay.
All right, good. Well, that's very interesting. So that's correct. 82% of you felt that coronary angiography with consideration of revascularization is the next best step. That's exactly right. So this patient has a high TIMI risk score, 5, so he's increased risk for adverse event. The best approach would be an early invasive as opposed to an ischemia-guided approach. If he's willing and doesn't have some sort of major contraindication. So again, his GRACE score, if you calculated it, would be about 140. So angiography within the next 24 hours would be appropriate for this gentleman, as long as he stays asymptomatic. And we saw why that was. Now, I don't have a slide on it, but the reason that the answer about risk of PCI is, which some people chose, is 1 in 1,000. That would be a low estimate even for a component of PCI. So generally, the risk of death with elective PCI is 1 in 500. It's less than 1%, but it's still not 1 in 1,000. And the risk of a major event with even elective PCI, including bleeding or infarction, within 30 days is up to 3.5%. So you need to consider that. And in acute coronary syndrome, the risk would be considerably higher. So the risk is not small with PCI. It's just that the risk is outweighed by the potential benefit.
Okay, so let's round this out, and let's say this guy had a GRACE score of, let's say, 90, and the troponin wasn't elevated.
Right.
What would be your options in this person with kind of stuttering pain, ST segment depression, but nothing else? What would be your options in this guy?
Well, the stuttering pain is a concern because not many of us would stress the guy, I think, with stuttering pain. So still, if he's having stuttering pain that continues to recur, angiography is probably the most straightforward thing. You consider other things if he doesn't want a catheter. I mean, you could consider CTA, I suppose, to exclude disease, but it's not going to be completely confirmatory. We'll hear more about that. But I think if you're able to stabilize the patient, he does not have recurrent pain and is relatively low risk, certainly an ischemia-guided approach would be perfectly reasonable. Echo and stress evaluation.
And so the ischemia-guided approach means to echo, and if ventricular function is down, you'd go to angiography.
Correct.
Because of the life-saving with 3-vessel disease. If, in fact, the ejection fraction is normal and he doesn't have any further pain and his GRACE risk is 90, you said you would stress him, right?
Yep.
And when would you stress him? Would you stress him before he dismissed from the hospital, or a month later, or 3 months later like we used to do?
Yeah, if he's totally stable, I think even in the same hospital setting it'd be reasonable if he's stable. So you could defer it a little bit if he wanted to wait, but as a total aside, we know from our patients in psychology that if he decides that he wants to wait, he's going to wait forever.
So you'd put him on some type of a stress test before he leaves the
probably
hospital.
as long as he's ultimately willing. Don't want to twist his arm. Don't want to coerce him, because the results of the stress test will lead to further action that he has to be comfortable with.
But ischemia guided means that you can't just let him go. Ischemia guided means that you have to look for ischemia and you have to look for ventricular function before you let him go.
That's right. That's why in the vast majority of these cases it's referred to as a delayed invasive approach, because a lot of these patients will go on to angiography anyway.
Yeah. Okay, well, thanks very much, Greg. Let's give him a round of applause here.